Okay, so here we go. So I would say that I saw a 40-year-old woman in the pain clinic with a 2-month history of right foot pain following being run over by a car. She sustained metatarsal fractures, which are being managed conservatively. My differential diagnosis of the fractures or of the pain is evolving complex regional pain syndrome. However, she did not meet the Budapest criteria for diagnosis. This is associated with poor sleep, and there was an element of catastrophization where she was stating her pain was 20 out of 10, so magnification. The pain was burning and sharp in nature. In terms of other medical problems, this woman was a smoker. She also described escalating alcohol misuse, drinking up to 4 bottles of wine per day after the injury. She also has a history of chronic abdominal pain, which unfortunately I did not have enough time to explore. In terms of psychiatric history, she has a history of bipolar affective disorder, and she appeared to have a depressed mood when I reviewed her in clinic. She also appeared anxious. However, she reported that she was not suicidal. The patient had a history of substance abuse of amphetamines for the past 4 to 5 years. In addition to this, it appears that she has what borders on polypharmacy with the use of 5 medications, including diazepam 20 milligrams Nocday, pregabalin 150 milligrams TDS, paracetamol, a sustained release dosage of diclofenac, and intramuscular pethidine 50 milligrams QID. I am somewhat concerned about the intramuscular pethidine requests in light of her previous opioid use of morphine for sleep. From a functional point of view, the patient stated that she was unable to weight bear, but it was reported that by nursing staff that she was observed to be able to weight bear from the bed to toilet. There were clearly some psychosocial complexity with the patient being a Caucasian, born in Canada, who is now living in Hong Kong. She has a 20-year-old daughter and a 14-year-old son, and was previously a kindergarten teacher, but has been unable to work since the development of her chronic abdominal pain. She was a former champion cyclist and found it distressing that she's unable to perform to the same elite level. The patient's expectations were, well, I don't know. My differential diagnosis, as mentioned, is ongoing non-union of her metatarsal fractures or complex regional pain syndrome. In terms of my management, the first thing I would do is speak to the orthopedic surgeon to clarify the diagnosis and to review any previous imaging, including previous x-rays, any bone scans, any CT scans, or any MRIs of the foot. If I were able to confirm, or I would go through the Budapest criteria again to ensure that there was she did not fulfill diagnostic criteria for complex regional pain syndrome. I would ask her to stop smoking, as this will impair any healing of her foot. I would adopt a multidisciplinary pain management approach, or I would discuss this with her to see if she's open to psychology and a physiotherapy approach to managing her pain. From a pharmacological point of view, I am concerned about the intramuscular pethidine and the potential development of an opioid use disorder. To that end, I would prefer her to be on oral medication but as a compromise, I would be open to the use of intramuscular tramadol, which has less respiratory depressant effect. I would consider the use of an antidepressant such as duloxetine or amitriptyline, especially given that there may be a potential neuropathic element to the pain with the use of the burning pain descriptor. Given that vitamin C is a differential, the addition of 500 milligrams of ascorbic acid daily for 2 months would not be unreasonable given a favourable benefit to risk ratio. I would like to discuss with her psychiatrist potential management and the stability of her bipolar affective disorder, and any potential use of psychiatric treatment to help stabilise her mood and potentially help with management. I am somewhat reluctant to use any interventional procedures with her, in particular the use of lumbar sympathetic blocks to manage her complex regional pain syndrome, given her psychiatric disorder. That it would be something that I would have to discuss with her psychiatrist and an orthopaedic surgeon using a team-based approach. The other thing that could potentially be used for complex regional pain syndrome, which again I would be reluctant to do, would be the use of nerve stimulation. And that's it. And then I'd say, I'm just trying to think if there's any other management that I can think of, but that's about 7 minutes.
Yeah, thank you.
Okay, so what do you think, Alfred?
Yes,